Hello and welcome to this video on IV cannulation. So what is an IV cannula? An IV cannula is what some people just call an IV. It's a thin tube that we put into a vein to allow us to put things in or take things out of said vein. The proper term for a cannula is actually also catheter, because that's the thin tube that you're putting in, but catheter we usually refer to an indwelling catheter or an IVC, which is the one that takes urine from the bladder. So I'll refer to it as a cannula, but you will sometimes read it as a catheter. Same thing. So an IV cannula is placed most commonly in hospital settings, but as a GP I do put in cannulas every week, and this is often to give things into the body. So this can be IV fluids, this can be antibiotics, can be iron, can be blood. Very rarely is it used to take things out of the body, and I will touch on this in a little bit, so taking blood samples from cannulas. But more often than not, it's putting something in. As for location, the most common place that a cannula is placed is the antecubital fossa, or the inner crease of the elbow. This is because there is very superficial vessels here that are straight and are pretty easy to find, and anatomically you can almost guarantee everyone's got one right there. So a vein right there. That being said, we do often put cannulas in the hands, especially for operations, because it's easy to move out the way and adjust and things like that. Sometimes you'll find them put on the outside of the wrist. Very rarely I have put cannulas in the forearms and the upper arms. I've also put cannulas in scalps before for neonates, and I have put cannulas in feet before, though this again is not ideal. This was always in an emergency setting. Why not the feet? It's dirty, people walk around on it, it's more likely to get kinked, knocked, put out, that sort of thing. So yeah, hands and antecube fossa, most common places. On the note of the wrist, there is a vein here that was colloquially called the intern's helper vein. Just to let you know, it's very painful when you get one put in there, but it can be a lifesaver for both you and the patient. What will you need when you're putting in a cannula? You'll need a patient, obviously, who's consented to this, except in emergency situations. You'll need a cannula. So cannulas are gauged by size. The smaller the number, the bigger the needle. I don't know the exact measurements, but I was always told it's how many of those needles you could fit into a certain sized circle. So if you've got 24 gauge, it's because you can fit 24 of those needles in. So there's a lot smaller. If you've got a 16 gauge, you can only fit 16 needles in that same circle size. So they're a lot bigger. So the most common size that we use is a 20 to 22 gauge, so a pink or a blue cannula. I think colours are Australia-wide, but it may only be Queensland. Very rarely I've seen people use yellow, which I believe is the 24 gauge, so the much smaller ones, used a lot in paediatrics. In obstetrics or emergency situations, quite often you put in a green cannula, which was 18 gauge, but I have also seen 16 gauges and put in 16 gauges myself. If I'm not mistaken, a blood donation needle, which is not technically a cannula, because it's still the needle in your body, not just the tube. I believe they're 14 or 16 gauge, so much, much bigger. For good reason, they're taking and giving, and anyway, lots of flow. Actually, that is a good point to make. The size of the cannula will determine how quickly you can give things. So that's why in obstetrics and emergencies, you want to have a bigger cannula, because you want to give fluid or blood or whatever it is quicker. If you're just giving antibiotics, and I say just because sometimes that is life, saving, often it doesn't matter how quickly you give it, in the sense that it won't make someone better quicker. There are rate limits for antibiotics because it can burn the vein, and it can be very, it can be viscous and things like that, but this is not a discussion about which cannula to put in necessarily. It's just a matter of there are different sizes. Pick the one that's going to suit your needs. So all I've mentioned so far is you need a patient and a cannula. You'll also need a tourniquet, a alcohol swab, a bung, a syringe and normal saline to put in that syringe, tape to put it down and a hyperfix, a bluey, and sometimes you'll need an extra set of hands. Don't forget your own hand hygiene, by the way, so you should always wear gloves and wash your hands before and after. Remember the 5 moments of hand hygiene. So step 1, find your patient, consent them, wash your hands, and find which vein you're going to use. So quite often I'll ask patients, hey, is there an arm that people get blood out of easier? And often they'll go, yeah, this one has nothing, use this one. Listen to your patients. Sometimes you'll find a vein that no one else has been able to access, or that wasn't prominent before on the bad arm, but listen to them. They know their bodies. And sometimes, you know, you'll put it in the arm that they said was going to be the better arm after trying twice in the bad arm, and well, not so fun. So tourniquet should be placed above the area that you're wanting to go for obvious reasons. The reason we put the tourniquet on is we want to fill the veins below with blood and reduce that venous return. Putting a tourniquet on for too long can make a difference sometimes, mainly if you're collecting blood whilst you're putting in a cannula. My understanding is, and again it's very rudimentary because it's been a few years since I was in hospital medicine and therefore collecting bloods through cannulas, but it's really the potassium. As the blood hemolyzes, potassium can go up, and so you don't get an accurate sample. But anyway, so you put your tourniquet up. I would suggest looking as far distally as you can before you go for more proximal areas. So start at the hands, so you can put a tourniquet up on the biceps, so you can put it on the forearm. See the veins of the hands. If you're not happy there, check the wrist. If you're not happy there, move up to ACF. Mainly because if you're going to reattempt something, you want to reattempt it in an area above the area you just went through. This is for a number of reasons. If you damage a vein, so blow a vein or whatever happens in the ACF, theoretically, the flow up, these all flow back up through that area, so you may impede that ability. Also infection risk. So try to always go for a cannula you're pretty sure guaranteed to get, because you are making a connection between the outside world and the internal system of the body, increasing infection risk. But let's say you found your vein, and a good vein is a straight vein that is long enough for a cannula to go through, has no knobbly bits, which are the valves, and doesn't bifurcate, so it doesn't split. Cannulas very rarely turn corners. So you found your vein. Fantastic. Let's set up. So take the tourniquet down, don't forget this. Put the bluey underneath. There's an old myth that I was told that if you put a bluey down, you'll never have a bleeder. If you don't put a bluey down, you'll have blood on your hands. You want to set everything up. So using aseptic technique, opening up your tray. So I didn't mention it in the things you'll need, but you will need some sort of sterile field, or at least clean field. Have your alcohol wipe ready, have your cannula ready, and select the correct size. I suggest loosening the cap. I would have your bung ready. So the reason you have a bung is to connect the cannula to whatever is going into it. So whether that be a giving set, a syringe, blah, blah, blah. I will often fill my syringe with normal saline and attach it to the bung straight away, making sure that I don't touch the sides of the bung. This, again, is an infection risk thing. So you've got all of that set up, put your tourniquet on, wash your hands, don your gloves, clean the area, and they do say use, concentric circles, up and down. Doesn't really matter as long as you clean the area, and once it's clean, don't touch it. Good thing about alcohol is it actually does irritate the veins and make them a little bit bigger, so you can give a good vigorous rub, because the friction also makes them a little bit more plump, which means that you might be able to palpate them a lot easier. Good tip that I found when I was in hospital medicine is use your alcohol swab to guide you. So they're often squares, or they're always squares. Use one of the points to point down which way the vein's going. So I don't know what you can see. I don't have a viewfinder, I can't see myself, but let's hope that you can see this. So my vein's going up this way, but if it was going this way, I would put the alcohol here pointing in the direction. It's not on the area I'm going through. And the next step is anchoring the vein. So veins can move and roll and be really irritating, so a good anchor is required. And if you've got that alcohol on there, you kind of know where to anchor. Then you want to get your cannula, and this is where I have a prop. Don't laugh at me, I have a toilet roll, a chopstick, and a straw. So this is your vein. Hopefully you can see this gap, sort of the window into the vein. This is your needle, and this is the actual cannula. So the aim is actually to get this cannula into this vein, and the needle is kind of the way to do so, to break the skin. So I'm hoping this translates on camera. So you found it, you've anchored your vein, the vein's going this way. So what you want to do is at a 45-ish degree angle, insert your needle into the skin. At this point, if you're in the vein, as you hopefully can see I am here, you will get what we call flashback. So So flashback is a bit of blood coming up the needle, and you'll often have a viewfinder on the cannula to find this. Once you do, insert a little bit more, and this is very hard, there we go, flatten a little bit, you might be able to send just a tiny bit more, but the aim is not to put the needle in, it's to put the, in this case, the straw in. Now that you have the actual cannula in, which is the straw, you want to take the needle or the chopstick out. So as you can see, you've got the straw both on the outside and the inside of the vein. As you're removing the needle and leaving the actual cannula, you need to clamp down on the vein above the area of the cannula, because now you've got blood flow coming up that can go straight out the vein, and this is what we call spillage or bleeding when you're doing a cannula. So you can see you've got your cannula in, you've flushed, your bung's on, you tape it down, and you've just placed a cannula. Congratulations. Now dispose of your sharp, put it in the sharps bin. Anything with blood on it needs to go into clinical waste. Put everything away. So a couple of tips from someone with a couple of years experience. If you initially go in and you don't get flashback, don't freak out. You can do a little bit of digging, but mind you, this is uncomfortable for the patient. But if you're anchored and you're at the right angle and you know there's a vein there, you can sort of go, twist it a little bit, lower or increase your angle until you get flashback. Then you lower down a bit, advance, clamp, tourniquet off, bung, etc. The next thing is you will get quicker with time. It's actually really hard for me to verbalize all the steps because I'm at the point now where I just do it, and I'll subconsciously, or maybe that's not the right term, I will, without thinking, take tourniquet off, put bung on, put pressure on here. You will get through it. It will become very easy. It sounds like there's a million steps, and I guess there is, but it's not that bad once you get used to it. Another tip is get used to using an ultrasound to find a vein. You'll be able to see, where it is, make sure it's not a valve, make sure that it's not about to bifurcate. It can just give you that little bit of confidence that there's a vein where you're poking. You can keep the ultrasound on, put it in and see the tip of the needle enter the vein if you so wish to. Quite often I personally needed a second person to hold the ultrasound because I wasn't quite there yet with one-handed everything, but I was also not in the hospital system requiring that for long. And thankfully when I was on my anaesthetics term, I got a lot of cannula practice. Now I did briefly mention about taking bloods from cannulas. Technically you're not supposed to, and this is for a number of reasons. One, there is a bit of dead space in the cannula, so you may still have whatever liquid you've just pushed through, whether that be antibiotics, iron, normal saline, etc. Two, going through the cannula does risk the vein collapsing. So if you're, putting pressure, this didn't happen to me, however I know it can. Three, going through that is more traumatic for the blood flow itself than, going through a needle which is meant to be a out, not an in way, which means that you can hemolyze and have higher potassium like I kind of mentioned earlier. However, if you are in a pinch and you need blood and it's for something like a troponin or something that will not be affected by the hemolysis and the damage going through the cannula, then okay, take it. Quite often I would suggest drawing 10 mils and discarding it and then taking the next 10 mil, because that ensures that whatever was left in the dead space or around that vein itself has been discarded. Then flush your cannulas properly. If you are ever accessing a cannula, and this is a completely different video, make sure that you are cleaning it, so wiping it down on every access. Cannulas should be replaced every 3 days. However, every hospital has their own policies. Some cannulas can stay very healthy for up to 5 days, even 7, but most hospitals will have a legislation or a guideline that says that after so many days they must be resited to prevent infection. Because, again, high infection risk with cannulas, you've got a good, passageway from the outside weld to the inside weld. Because obviously you've got a good passage from the outside weld to the internal body. So bacteria do love cannulas. Just something to mention as well, any cannulas placed outside the hospital system once the patient is admitted do need to be resited. Sadly, they may be perfect cannulas, however, you cannot guarantee that the cannula was placed under the proper technique or, cleaned properly, etc., etc. We trust our colleagues, obviously, and especially our AMBOs are very, very good at this, and so are the GPs, just to plug in there. However, once that patient becomes your patient, you are responsible for the side effects of things, essentially, and the consequences of things. So you will need to resite any cannulas placed outside the hospital system. So I hope this helped. Thank you for requesting it. And if you've got any other requests, please let me know in the comments. Like this, subscribe, all that other YouTubey stuff. Until next time, stay safe and stay healthy, and I'll see you later.